complete the survey, those that do not attend the survey will not receive a certificate. Hold on a second. I apologize. Those that do not complete the survey will not receive a certificate of participation, which is equivalent to 2 hours. I don't know why it's bouncing my speech, so I guess I am going to say it with my paper. Okay. Those that do not complete the survey will not receive a certificate of participation, which is equivalent to 2 hours of continued education credits for your family peer advocate credentials, if you need any. I want to just go over a few housekeeping rules. If you need technical assistance, please type your concerns in the chat. Also, keep yourself muted if you are not speaking. Our presenter, Donna Marie Simon, would like this webinar to be interactive, so please use the raise your hand feature under the reaction button below your screen. Please note that due to the number of attendees, we may not be able to answer all your questions, and please reach out to Priscilla or myself if you have questions. We are also allowing a half an hour before this webinar ends for any questions. I know I now share information about the presenter, and as I mentioned, or I didn't get to mention, but the presenter would like this to be interactive, so please feel free to put your questions in the chat, and we'll do our very best to answer those questions. Regarding the presenter, Donna Marie Simon has been in the field of behavioral healthcare for over 15 years. She is a licensed clinical social worker and is certified in applied behavioral analysis. Donna has obtained her own business called Step by Step Behavioral Therapy, and her motto is anything is possible, one step at a time. Donna is featured under the website psychologytoday.com. She is now an approved New Jersey state provider. And after receiving her master's in social work and certified in ABA, Donna continues the mission of working towards building client-centered quality behavior healthcare services to enhance the quality of life for all service recipients, their families, despite their ages, diagnosis, or different abilities. Donna continues to advocate by building systems including training and support, and focuses on trauma-informed care as well as curriculum for staff, clinicians, administrators, and families. So without further ado, I introduce to you Donna Marie Simon. Thank you so much. Donna, take it away.
Good morning, everyone. Hi, thank you all so much for being here, and happy Friday. It is such a pleasure to be working with families together, and working with Diana and Priscilla has been such a joy. So thank you so much for finding me and for inviting me to speak to you all today. It is such a pleasure to be here, and I'm hoping that you all come with me on this journey of how trauma-informed care approaches could bring a gentler applied behavior analysis procedures to everyone that we serve. This is a very strong passion of mine. I've been in the field for a really long time, and just seeing some of the procedures that carry out and some of or individuals' reactions to some of those procedures has always been a guiding principle of mine. Some of the things just seem like they're not informed, and we don't know what people's experiences are. So this has been a big focus of my training and curriculum development over the last couple of years. I just want to say also from the beginning of this that I cannot give really specific advice. So if anyone has a case that they're thinking of or that's triggered in something that I'm saying, or wants a direction about something very specific, I'm not able to really give you specific advice or specific procedural advice, only because I don't know the case, and that would really be unethical of me. But hopefully I can give you some direction and some places to go for support that you might need, or some ideas. With that being said, I do like my workshops to be very interactive. So if there's a question that comes up, I might throw it back to you. I'm in New Jersey, and what I've learned working with Diana and Priscilla is that things do work very differently across the states, which sometimes hurts my heart because I really feel that New York also needs the support that we have available in New Jersey. But that's part of this presentation, to work with the advocates to get services for everyone, despite where they're living. So the name of the presentation is A Practical Guide to Trauma-Informed Care and Approaches. We're going to be going over some difficult conversations, and I'll be telling some stories that might be difficult to you all. So if you feel the need to walk away, need to take a breath, take a minute, feel free to do that. We're here for 2 hours. If you do need to remove yourself from the webinar altogether, I'll just ask that you just let Diana and Priscilla know that you had to remove yourself. This way, I know there's some credit that's attached to this for your ongoing continuing education and participation. So I don't want to see anybody lose that opportunity just because something that we've talked about might have triggered. I mean, it is trauma. So I just want to be very sensitive to that. A little bit about me. This is just something that I have to put on all my slides. I recently obtained my clinical license to practice social work in the state of New Jersey. I've built programs all across different ages because I don't feel that one type of support should be given to one age versus another age. So I've worked really hard to bring excellent services across adults and children as well as our elders. I've worked for not-for-profit in the private sector as a direct clinician. I've started behavior support programs pretty much across the state, both on a consultant level and as an employee. I also teach at Kean University, so I'm there as an adjunct teacher, and I have the pleasure of teaching a supervision course for incoming and new BCBAs, which is informed by some of these approaches that we'll discuss going forward. The reason is, and I'm not quite sure, it might have been Nelson Mandela who said it, is that the only way to change future generations is to get into the education system. So I'm hoping to shape up our future clinicians to be more trauma informed in their practices so we could really be sensitive to the needs of others. I sit on the regional Human Rights Committee, and we do review some of these procedures that might seem either punishing or has the potential to be re-traumatizing. Okay, so this is a poll that I'm going to see if I can put up. I'm hoping I can. The polls should be popping up on your screen. And let's see. So the first one is, who are you? Hopefully everyone is seeing that on their screen. If you could just let me know who you are. If you're a parent or a caregiver, a service recipient, a clinician, perhaps an educator, which would mean a teacher, a counselor, a social worker, or an administrator, or perhaps none of the above. I thought I encapsulated everything, but maybe I did not.
But what if you're more than one?
Pick the one, I guess, most prominent. Is that fair? Or the one that resonated with you when I first asked the question?
I don't see anything for like peer advocates on there.
That would probably be under clinician.
Thank you.
Of course. Okay, so it looks like almost everyone has answered. Okay, so we have about 44% of people that are parent and caregivers, 11% of people that are service recipients, 15% are clinicians, 14% are educators, teachers, counselors, administrators, and 18% are none of the above. Who did I miss? For someone that falls in the none of the above category, if you can give me some feedback, who I overlooked.
Hi, my name is Carrie Banks. I'm with Brooklyn Public Library, and I am a librarian who serves
Oh.
individuals with all types of disabilities.
Wonderful. Well, welcome. Thank you so much for being here.
Thank you.
Thank you for the feedback.
Good morning. My name is Sabrina Meredith, and I'm a parent.
Welcome, Sabrina.
Thank you.
Okay, I'm going to end the poll. For those of you who are just joining, I'm so sorry. We just had a quick poll. I just wanted to see who I was speaking with today. You all know about me. It's my turn to learn a little bit about you, right?
My name is Denise Miner, and I'm a foster parent.
Welcome.
Hi, my name is Gladys Stewart, and I didn't see the peer advocate choice, so I just put none of the above.
Okay, wonderful. Thank you so much. Okay, so that was the first one. And I'm going to ask you another question. And these are all anonymous polling. I don't know who answers. I have been exposed to trauma. True or false? Let me pop this up for you. And again, it's anonymous, so I won't know. Okay, or about 70% of the participants have answered. Just give it another minute. Oh, it looks like everybody is here. Wow, there's 71 people here today.
Donna, we have 90.
90. Wow. It's saying 100% at 73, but okay, so right now we have 84% of the attendees have said yes, and 16% have said no. We're going to retake that at the end of this and see how that has changed.
Donna, Maria wrote in the chat, COVID has exposed all of us, correct?
Wow, that is a very good point. And I think you've seen my slides in advance. That is one of the reasons why I started to develop this training for presentations just like this, because COVID has, and pandemics can trigger trauma and can be a traumatic event for us all. So thank you. That was an excellent point. Okay, so our workshop agenda, we're going to talk about what designates trauma. I'll review some signs and symptoms of trauma, what the trauma-informed care framework looks like, what is applied behavior analysis. We'll talk about the reinforcement and the punishment conditions, and how ABA and trauma-informed care can work in conjunction, and that framework could be side by side. And then we'll talk about how collaboration and effective communication could lead us all to be more trauma-informed for the people that are receiving services. So during questions, I'm going to be stopping in between some of the sections. If you could see my piece of paper, I have like little stick notes on there where to stop. And if you have a specific question, feel free to either raise your hand or you can type it in the chat. We do have everybody here that's kind of looking at the chat. I only have one screen and I'm not that tech savvy, honestly. So just bear with me. We're going to try to get to questions as I can. And then I'm going to stop and we'll have some open discussions in between. So hopefully that's fair. I'm also going to let you know that I'm originally from Brooklyn. So I was born and raised in Brooklyn, New York, and I could go fast sometimes. So if I'm going too quickly, please just raise your hands, let me know, or type it in the chat, And Diana or Priscilla will send me a text message to say just to slow down. So if my Brooklyn comes out, I apologize. And again, just that disclaimer, if anyone feels the need to leave the presentation or if anything is triggered, feel free to walk away from the screen. And if you do need to leave the presentation, just let Priscilla and or Diana know that you'll be leaving. All right. So the reason why I became a BCBA. So first of all, I got my master's as an adult with 3 adult kids. So I did go back to school and I was working as a social worker for many years and I really loved my job. I had a friend who had said, well, you're really good at writing policy. Can you help me write a policy for this ABA program that I'm developing for kids? Like, sure. So I did my research, I put together everything, and she got approved after twice being turned down by the state. And she said, you're obviously my lucky charm and you obviously need to be here. Come and work with me. So I did. Took a part-time job as a single mom, going to school, and started working with her. And that's where I met Maddie. Maddie is a 16-year-old male who was living at home with his mom. Maddie had multiple increases in physical aggression towards his mom. And what that looked like for Maddie was he'd run across the apartment and jump on his mother and bite her on her head. He had sent her to the hospital on multiple occasions. In addition to that behavior, Maddie also engaged in self-injurious behavior in the form of hitting his head against a hard surface. So whether that be the floor or the wall. Maddie was nonverbal and used some picture cards or PEC systems, as some people know them as, but it was like a multitude of different systems to communicate his wants and needs, but didn't really have much fluency with it. So he was really unable to communicate what was going on. So when I walked into Maddie's life and did my initial assessment, I had said, I think we needed a medical rule out because it seemed to just be happening across all different conditions, but only while he was at home. Maddie's history was he had lost his dad, and then his aunt had passed within the same year, and he had moved his home twice in that year. He was going to the same school, but his environment just kept changing, and all these people that were really important to him just kept disappearing from his life. Well, when I said that we needed a medical rule out, because I wasn't sure, it was happening everywhere, Mom became very angry with me and said, she doesn't know what she's doing. She's not a BCBA, and I don't want her on my case anymore. So they removed me from the case, and another clinician stepped in. Another clinician just went forward with communication training, which would have been my next step, but went forward in that aspect. And Maddie had such a severe behavior and put his mother in the hospital for the very last time. And Adult Protective Services came in and said, you can no longer have your child living in your home, and removed him. Yet another loss. So Mom recovered, and Maddie went into a residential facility for stabilization, where he had an extreme behavior of self-injurious behavior and physical aggression to the staff. They put him in a hold, did it incorrectly, and while he was face down, continued to hit his head on the floor with, I think it was 7 or 8 people on top of him. And Maddie passed away at 16 years old. The reason why I tell you that story is, even though I had already had my license, even though I was already practicing in the field, I thought, no one is ever going to go through that again just because I don't have 4 letters. My recommendation would not have changed today or back then, but I just felt that overlooking that very important pieces, the medical rule out, the trauma that he had been under all of those years, was something that was not responsible. So I went back to school to get my Bcba. After, because he passed away in a residential facility, they did an autopsy and they found that Matty died of sepsis. He had an untreated tooth infection, which was why he was biting his mother, which was why he was hitting his head against the floor and hard surfaces. Because if you ever noticed when you have a toothache, if you press on it, the pain goes away. So that's one of the reasons why I became a Bcba, and I'm honored to be in this position every day. So experiencing a trauma can change the way a person perceives the world. Trauma is very subjective, right? We all experience it in a different way. And part of our learning history and what we've experienced throughout our life up until this point shapes how we see a trauma or how we cope with a trauma. So we're going to learn what learning history is throughout the presentation. And it's an environmental condition that occurs before, which is called an antecedent, and after, which is called a consequence, behavior across time. So it's basically all the entire sum of all of our experience with people, places, situations, which are modified, or as we call it, conditioned, based on these interactions. And as I said, we're going to be talking about this more in more detail later. So what is trauma? Trauma-informed care practices started around 1970, and it started in the medical field. It became an approach for patient care when doctors started seeing that there was physical and mental needs that were unmet in our Vietnam War veterans. So trauma is all of these things. There is 1, 2, 3, 4, 5, 6. There are 6 definitions of trauma right here on this screen. It could be an event or a circumstance resulting in physical harm, emotional harm, and or life-threatening harm. It could be results from an exposure to an incident or series of events that are emotionally disturbing or life-threatening, which has lasting adverse effects on the individual's functioning, mental, physical, social, emotional, and spiritual well-being. It could be the distress following an exposure to a traumatic or stressful event. It could be an exposure to an event or series of events that adversely affects functioning and well-being. It could be seen as an emotional response to a distressing experience. Trauma has no boundaries. It can affect anyone at any time. According to the National Center for PTSD, in 2014, so that was quite a number of years ago, 60% of men and 50% of women will experience at least one traumatic event in their lifetime. Yet we as a field still do not have one way to define trauma, which leads to this difficulty in measurement of coming up with effective interventions, particularly in the field of ABA, where we measure behavior that we can observe. So these multiple definitions of trauma needs to really be looked at for future direction of treating something that affects so many people. And as I said, trauma is personal. So since trauma is a subjective experience, it is so difficult to apply that concept in a systematic way across human beings. So this is clearly not an exhaustive list of trauma, but this is just some things that, or some events that can cause long-lasting effects on functioning. And these things can be direct or indirect. So that could mean that you have experienced this yourself, or that you've witnessed someone experiencing this. So acts of violence, grief, death of a loved one, natural disasters, neglect, continued isolation, abuse, sudden changes in daily routines, accidents, substance abuse, divorce, bullying, verbal aggression or threats, the pandemic. So whoever said that, you get a gold star. Yes, the pandemic did definitely affect most of us. War or military service, poverty, or any secondary trauma. Secondary trauma occurs when we're caregivers, when we're hearing people's trauma on a regular basis. We see this a great deal in our helping professions, and it can be one of the factors that leads to this increased burnout that we feel. It also could lead to decreasing staffing, which then affects our service recipients with the sudden changes in daily routines. So it's a cycle. Some reactions to trauma that you might see, and again, not an exhaustive list and can be varied. Shock, avoidance of people or situations, withdrawal, aggression, a flat affect, or like that flat facial expression or lack of facial expression, mood changes, including irritability, depression, sleep disturbances, which could be increased sleep or decreased sleep. And sometimes there might be nightmares or night terrors involved. There could be a lack of interest in preferred activities or once preferred activities. Increased startled responses. So somebody coming up alongside of you and then suddenly the person jumps. There could be guilt or shame, self-blame. You see that a lot. People victimize themselves, think that they brought it on themselves. There could be difficulty concentrating. We may see these increases in behavior events at certain times of the year, anniversaries, birthdays. We call them triggering events. So triggering events could also be a certain caretaker. So you might remind someone of the person who was attached to that traumatic event just by wearing glasses or having a beard or being a male or being a female or being a certain color skin. If someone was paired with that adverse event prior and you're coming into their lives, that could be, you could be a triggering event to that person. But that's the kind of stuff that we don't know until we actually see the person's history and kind of understand why.
Donna, I love what Monique just said, that even a smell of fragrance. And that is
Absolutely.
that is so true. That is so true.
That is so true. Thank you, Monique, for sharing that. Absolutely. The smell of a fragrance, right? It could take us back in such a great way, right? And it could take us back to such a horrific event in our lives. Thank you so much for sharing that. And thank you, Diana, for including that.
Mark Anthony has his hand raised.
Oh,
Mark Anthony, you want to share something?
I appreciate you. As much as we want to rid the world of trauma, as much as we want to heal each other, and of course, it's especially important to love and to talk to one another and heal each other as well as heal oneself, there can never be light without darkness. There could be no good without evil. In other words, we have to integrate the evil within us and appreciate ourselves for our imperfections as well as our perfections. As long as we don't have our darkness get the best of ourselves, we will be okay. And we'll be more self-aware to each other, to ourselves. Thank you.
Absolutely. Thank you, Mark. That was so well said. Oh, did I mute myself? Oh, okay. That was so well said. And integration is so important. It's so important. And as a clinician, both on both sides, that's what I look to do. I look to integrate that and to accept ourselves for who we are with all our imperfections. So that's wonderful. Thank you. All right. So according to the DSM-5, which by the way, is not the newest, they just came out with a newer version, which I did not have access to when I developed this. So my apologies. But from 2013, the DSM-5 has multitude of pages. I think it was 25 pages actually devoted to trauma and stress-related disorders. In the DSM-5, it's from 265 to 290, plus some of the surrounding pages on trauma and stress-related disorders. In the field of literature and practice, right here, you'll see like comorbidities. That's what it's considered. I don't like to consider things comorbidities. I actually like to call it co-occurring, because comorbidities just seem so final and it just seems like it's a suffrage. So I like to consider that co-occurring. So some of the co-occurring diagnoses that could lead to like these psychiatric diagnoses, more labeling of people, is reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, acute stress disorder, adjustment disorders, and secondary diagnosis may include anxiety disorders, obsessive compulsive and related disorders, and dissociative disorders. In applied behavior analysis, an actual diagnosis outside of autism does not matter. It doesn't matter. And autism diagnosis only matters in the world of insurances. Overall, we only treat the behavior that can be seen and observed. And we'll talk about that more later. So diagnoses does not matter. We're only treating what we see. Approximately 70 people with autism spectrum disorder also have a co-occurring mental health diagnosis, and 40% have more than one. So we're labeling people and giving, more medications and trying to work through all these things, but we might not be looking at the root cause of everything. I'm trying to go forward and I don't know why I can't. Oop. Yeah, I went too far back. Okay. Sorry about that. Okay. So there are 3 different types of trauma. Acute trauma is a single incident. Chronic is multiple and repeated incidents. And complex is multiple incidents or varied trauma. I am only going to say, if you or a loved one is experiencing any of the symptoms that we talked about already on these slides that last longer than a month, are intrusive to your daily life and functioning, bring about increased distress or increased emotional reactions. So if at this point, in hearing some stories, you've already had to leave the presentation, please, 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 please reach out for help. Speak to your physician, speak to a social worker, a psychologist, a counselor, or a family member or someone that could get you the help that you need.
Hello.
Donna, Claudia wrote in the chat what to do when the person is not ready to talk about the trauma.
Okay, fine. So it should be okay at 1 o'clock.
That is such a great question. If you are experiencing such distress that you can't function in your everyday life, that I would consider to be a crisis situation. But trauma is very much like an onion, right? Sometimes we're going in talking about one thing, and then we realize that there was some trauma that happened in the past. We don't always have trauma events in the forefront of our minds. There are many people that I work with that are, they come to me and they say, oh, my kids think I need to be here. I don't think I need a therapist. And then it turns out that, micromanaging and whatever their kids are complaining about turns out to be attached to a trauma that had happened, many years before. Our brains are really amazing, and our defense mechanisms that keep us safe sometimes protect us from those things. So I would say if you're witnessing or if you're witnessing or experiencing,
everything goes towards your deductible.
Please.
Okay? This is the least expensive plan option for all of you.
I'm
Once
hearing
you've
some
satisfied
HIPAA
the
information.
deductible,
I don't
you
know if we can
go
mute everybody.
5 lines down, you're going to see that you have a $20 code.
Donna.
Thank you. Thank you. I just, I was like, we're going to hear HIPAA information. Stop talking. Thank you, our techie. Yay. Thank you for saving the day. So again, if you are impaired in your daily functioning, I would say that would be a crisis situation. If it's someone that you're watching, please encourage them to reach out for help. And if it's someone younger than 16 or perhaps 18 in New York, please intervene as their guardian or caretaker. Hopefully I answered your question. Mark Anthony, did you have a question as well?
No, I just wanted to add to the last question that she had regarding about trauma. And I wanted to add that it is okay to allow the person to feel what they need to feel, because ultimately we are human. And if we reinforce positivity, it ultimately becomes toxic because we're not allowing our clients and clinicians to feel what we all need to feel in order to reinforce and to move on. Of course, it's one thing to feel pessimistic and negative, but staying there is really what causes the trauma and the symptoms within a person. It's that feeling of giving up that can overwhelm a person. Of course, feel what you need to feel, as I've said like 2 more times, but staying in that feeling is no longer good and unnatural. Thank you.
Absolutely. Thank you. I tell my clients to lean into the uncomfortable, right? Because that's where the good stuff is. When you squeeze a lemon, you have to squeeze it to get the good stuff out, right? Or when you peel back an onion, you have to keep peeling back the layers to get to that center, that part that makes you cry. So sometimes we have to lean into the uncomfortable parts of ourselves and the things that we don't want to see or don't want to talk about, because that's where the real healing begins. Absolutely. So thank you. Okay, so sorry.
To put it more philosophically, it is what you do with the feelings and how to cope is what truly defines you as a person.
Very true. Very true. It is all about communication. And it's not only communication with other people, it's the communication within ourselves, because we all have those little voices in our heads that tell us things every day, right? We all have oh, well, are you sure you're ready for that? You go to make this really great move. Are you sure about that? We have those negative narratives that play in our head sometimes. And sometimes the things that we've experienced in terms of trauma really do play into those voices a little bit. Okay, so some interdisciplinary treatment approaches are CBT, cognitive behavior therapy, trauma-focused cognitive behavior therapy, functional behavior assessment, teaching emotional regulation, prolonged exposure therapy, which in ABA we call desensitization, cognitive restructuring, EMDR, acceptance and commitment therapy, parent-child support services, both community and in-home, safety planning, programming for generalization and maintenance, and of course, medication management. So CBT, cognitive behavior therapy, trauma-focused cognitive behavior therapy, prolonged exposure therapy, EMDR, cognitive restructuring are all like psychotherapeutic modalities, right? So that's all my clinical social work stuff. That's what a psychologist would work on or a counselor. The functional behavior assessment, the behavior skills training, desensitization, acceptance and commitment therapy, programming for generalization and maintenance all fall under the areas of applied behavior analysis and behaviorism. So there is already built into the common treatment modalities for trauma, ABA is built in there. So I just wanted to go over some of those, and we'll talk about some of these in a little bit more detail, particularly ACT, which is one of my favorite modalities because it does cross over both the ABA and the psychotherapeutic licensures and modalities. So, why are we here today? And why are we talking about our service recipients and trauma? Because people with developmental disabilities, or as I like to call different abilities, are a population that are at greater risk for trauma and untreated trauma. They are more likely to experience potentially traumatic events than everyone else in the population. Why? Why is that true? Couple of factors. Some of our folks are not taken seriously. Some of our folks have a limited ability to utilize coping mechanisms, and that might be just because no one taught anyone how to utilize coping mechanisms. Some of our folks are non-vocal, or they might have cognitive delays, or there might be some physical limitations. There might be some difficulty with emotional regulation. There might be some perseverative thoughts or rumination, the constant replaying of that experience over and over again. Having a different ability is difficult and stressful to navigate to begin with in a world of atypical folks. Sometimes you might see an increase in internalizing behavior or externalizing behavior, internalizing meaning towards myself and externalizing meaning towards another person. Sometimes I hear a lot, oh, that's just who they are, right? So people are seen as just who they are, even though it might be a red flag for additional assistance that's needed. And there's something called diagnostic overshadowing. And it says that some symptoms are overlooked due to the assumption of it being part of another diagnosis. So I might exhibit similar symptoms due to something else, like cognition, for example. Oh, they just won't understand. In terms of providers and specialization and training, there's not enough focus out there. There's not a lot of trainings on these particular topics, or even how to deal with these issues that might come up. Right now, there's been a lot of focus on these topics. Some factors are considered like ACEs, the adverse childhood experiences, which identify some possible traumatic events that can occur during childhood. Overall, research has shown that children with developmental disabilities are more likely to have exposure to those risk factors. The most frequent ACEs are seen through those diagnosed with autism spectrum disorder. They are 3 to 4 times more likely than typically developing peers to be exposed to bullying, to be exposed to parental divorce and malnutrition. Those exposures in early childhood could lead to challenging or maladaptive behavior patterns from the time of the event, carrying all the way through adulthood. The answer here is that we really need to develop and advocate for resiliency. And I think that's what Mark Anthony was referring to earlier. We have to increase safety through community supports, increasing self-awareness, developing coping, and really advocating for empowerment, which is simply control over our lives. We know that people with different abilities have increased stress and increased potential traumatic events. We know that there's increased caregiver strain. There's less resources, whether that's in the community or financial resources. Divorce is common. Sometimes residential placement is necessary due to safety reasons. There's private programs that needs to be implemented. So all of these things are just perpetuating the potential of traumatic events. So I think if we advocate and continue to specialize and train incoming clinicians, advocates, support coordinators, and ourselves, that we could really get to the solutions for this topic and how to provide more supports. So does anybody have any questions or comments? Or I'm going to go into the chat really quick. I just hope I don't lose my take ownership of your pain. Absolutely. Let's see. He's not ready to talk about. Okay. Claudia, we can probably talk about that a little bit more. Mental health. Absolutely. Jenny mentioned that many therapists feel that they are not equipped to treat mental health when an individual has ASD. Absolutely. Jenny, I agree with you 1000%. My whole mission in being in the field has been to find ways to integrate the mental health component and my BCBA and the love of ABA component together. There is such a need for mental health treatment, not only across our nation, but with this population specifically. So thank you. Thank you for sharing that. Yeah, we can give people, re-traumatizing people, absolutely, by doing certain procedures. Am I missing anything, Priscilla or Diana? Or does anybody have anything that I can't? I can only see 4, 1, 2, 3. I can only see 5 little squares. So I don't know if anybody else is raising their hands.
You're good. You're good. You're covering it.
Okay.
And remember that we have the Q&A. We have a half hour for, 30 minutes of Q&A. So write your questions down and we can just keep going. And then we did 2 halves that half an hour, 30 minutes.
Okay. All right, perfect. I set my little timer. So Chris, I love Brene Brown. I love Brene Brown. Amazing, amazing speaker, amazing person. Absolutely, I agree. There is no parent-friendly training. Actually, Debbie, that's what we're working on. We're working on building these supports. We really need to come up with a parent-friendly training on this. And that's part of what I'm trying to start here, right? Is starting this conversation. Conversations are so important in our field, aren't they? It's what leads us to the next best practice. and the next best way to provide excellent supports to our folks and to our families and to each other. It is all about communication. So I'm going to tell you another little story. I always call these like story times with Donna. A lot of people call them case presentations. I don't like to necessarily call them that because it's not necessarily a clinical presentation, but I will give some clinical aspects about this. So this is the story of John. Of course, all names have been changed. And I want you to kind of think about if you think this is neglect, or if you think this is circumstance, okay? So John is a 28 or 29-year-old male who has a history of very severe aggressive behavior. Aggressive behavior for John specifically looked like taking your hands in the shape of a claw and swiping towards somebody's face, arm, or upper torso. And John did have some pretty sharp nails. 1 month, he had 237 aggressive behavior towards me. I actually had a cut on my arm. I was working at a pizzeria back in the day. I was moonlighting, and I had a burn on my arm. And John came at that burn specifically to open it up, to have me bleed. Literally would go after that spot until it bled. So the story of John is mom was getting older, and he was in a residential facility. And he wasn't able to go home on the weekends as much as he would have liked. He used to go home every weekend. And his co-guardian was not available all the time. So he's living in this residential facility, has all these increased aggressions towards staff and peers. Do you think many people were like hugging John, giving John a pat on the back? Or do you think perhaps John was being looked at as this monster who can really hurt people, right? And I say monster tongue in cheek. I would never consider anyone a monster. But there are times that we read history of our folks and say like, oh my gosh, that's a lot. That's dangerous. And we feel fear, right? We just feel fear. We feel like maybe we might be unsafe. But let's try to flip that and look at the other side. The other side was looking at a functional assessment. John only had these behaviors towards me and one other staff member. It took me about a year to kind of see this. Most people avoided John. But what I would do, and the other staff member would do, is give John a lead along. So a lead along is not crisis management. It's just a very gentle way of moving a person so you can both remain safe. So what you do is, and if you all just take a minute and put down your pens and put your hands directly in the center of your body, palms facing each other, and push against each other, trying to keep it in the middle. So if you push your right hand, you'll move over. And if you push your left hand too much, you'll move over. But that center, right, that center position is called equal and opposite pressure. So what that lead along does is it gives that person equal and opposite pressure. So if John would have leaned into me, I would have balanced that pressure moving back to him. It is not intrusive. It is a very gentle way of moving a person forward. But that was the only commonality that I had and the other staff member had, making us realize that maybe John was looking for some pressure or some touch and not necessarily having people move away from him. So one day, John came at me and I put my finger, just a single finger, on the center of his palm, and I pushed. And immediately John stopped and dropped his hand and started melting. And it reminded me of, and not to be too silly about it, but it did remind me of, if anybody has seen like The Wizard of Oz, like, I'm melting. He literally melted with each pressure point that I gave him. And I just left my hands in one spot and he was pushing his arm against my hand. And then it moved up to his shoulder and he literally just dropped into a chair and became a different person. I was very fortunate in this agency because at the time we had a holistic therapist involved. And she had just started. And I said, can you come and please take a look at this and do an evaluation? Because this is kind of outside of my wheelhouse, right? I mean, as a social worker, can I identify like somebody needs touch and pressure? Yes. But as a BCBA, that's totally outside of my scope of practice. She did an evaluation and she saw that he would benefit from massage therapy, which would be pressure, which would be touch, but he didn't know how to accept it. He was only getting it when he would aggress towards someone. So from a BCBA perspective and an ABA perspective, we taught him language. We taught him to communicate that he wanted a massage. He would then go and meet with a massage therapist. I mean, this took many, many months. I'm just trying to keep this a short story. He would go get his massage. And do you know this person who could only work in a one-on-one office after like 7 or 8 months was now going to every program area and aggressive behaviors dropped down to like 3 or 4 going forward. So he didn't have to be isolated anymore. He was able to go visit his mom because these aggressive behaviors weren't happening. And it was all because he wasn't getting physical touch. The man was not getting hugged. What do we know about babies? Without touch, we all wither away. So was this neglect? Was this neglect on the part of his caretakers? Or was it just circumstance? Was it just not seeing the other side of the story? So let me go into the chat to see if anybody said anything about co-occurrent behavior health. This training should be in that field. True. Circumstances. Okay, I'm seeing. Absolutely. Yeah, you know what, Veronica? You're right. It might have been both. Because people didn't look to that, right? They were worried about their own safety and not necessarily providing for themselves. But yeah, it was mostly circumstances. If people would have taken the time to really understand, John, honestly, John opened up a whole world of opportunity for the integration of this field and looking at things from a different perspective. And just so you know, I don't know how many of you are working in the adult world, but to get an occupational therapy evaluation on an adult is almost impossible. So we were very lucky to have the massage therapist, although she only stayed for a short amount of time. Okay, so thank you for going on my little story time with me. Okay, so let's get into trauma-informed care. So trauma-informed care focuses on some core concepts. The first thing that I'd like everybody to remember is trauma-informed care, just in total, presupposes, so it already assumes that more people have been exposed to trauma than have not. Okay? So we're looking at everybody through a trauma-informed lens. It focuses on core concepts. 1, acknowledging trauma and its potential impact, establishing safety and trust with the person, providing choices, which leads to empowerment, and building skills. The client's ability to scope integrates a thorough knowledge on the trauma, its potential ramifications, and into every aspect of treatment, not just some, in every aspect of treatment and every step. I have to say that trauma treatments do not begin until the client is safe and the trauma cannot be ongoing. So if anybody is working with someone who is being exposed to a trauma, that trauma cannot be addressed while the person is still undergoing that trauma. So the overall focus of trauma-informed care is for the person to regain control back over their lives. So empowerment. For clinicians, we need to look at our assessments and our assessment procedures and really obtain a detailed history. We really need to look at ourselves and how we're building that trust and establishing safety and building our rapport with our folks. We need to look at how we could increase choice of goals, choice of things to do, choice of skill acquisition, and what skills would be pivoting to the next skill. What skill would be the most fundamental skill to open up a whole new world for our folks? And lastly, and I think this is a very important part, is letting the person take the lead in treatment. And this is really counterintuitive to a lot of us who have been in the field for a long time, right? We know we're the experts, we know better. Who is the expert on that person other than that person? People know. If we observe behavior, we will know what people are comfortable with or are uncomfortable with. Okay, so some trauma-informed approaches. Assessments. We need to ask questions. Lots and lots and lots and lots and lots of questions. And I'm going to show you a little survey that I have found on one of the websites, so that'll be coming. And Diana, just remind me, I want to send you that PDF as well, so you can send it to people if they want to use it.
Thank you, Donna.
Of course. Ask lots of questions. You want to find out that rich history of people. People are robust, right? We're dynamic. We have a lot of things going on. And we might have to be very compassionate, of course, because there is no kind way, right? As someone had mentioned earlier, to ask about specific traumatic events. Or you can start very carefully by asking about specific changes in a person's life. Because sometimes we could find a trauma by seeing some of the changes that might have happened. We can say, well, what happened before that? So then we're going to include all the relative dates and very sensitively some of the events, history, into our treatment plans and our progress notes. It's so important. It gets lost over time. It really does. And it's so important for it to be shared. We need to incorporate the person into our treatment planning. We need to ask the person what they want to do. It, again, is not a matter of we know best, right? It's getting the person where they want to be. We need to be client focused. If we're not qualified or not trained in a certain area, or if something is going outside of our scope of competence, we need to refer to more qualified personnel. And if I didn't already say this in the beginning, I'm certainly going to say it now. I am not an expert on trauma. I am not an expert LCSW. I am not an expert on anything. I always seek to gain more knowledge. So if I don't feel something is comfortable and within my wheelhouse, I will refer to someone else. I will reach out and get a mentor. Right? I am just very passionate about this particular subject because it does blend both of my worlds. And I do see that trauma is everywhere. But if I'm not qualified, I refer to someone who is. So as clinicians, we're going to focus on the strengths of the person. Listen, it is so easy to see all the things that need to be fixed in our people, right? Or even in ourselves. But what about our strengths? We all have a strength, and that strength could be built upon every step of the way. I had a conversation with a family member recently about ADHD. And I said, you know, it's so funny how everybody looks at ADHD. That can really be a strength. And they looked at me like I was literally out of my mind. And I said, well, think about it. Someone with ADHD is very, very easily moving from one thing to another, right? Like, think about all the times that you're asked to multitask. And then there are times that you can get really hyper-focused and get through a really long project. Isn't that a strength? Some people get very overwhelmed when they're handed multiple things at one time. But so sometimes these diagnoses that we're putting on people are seen as like not a great thing, but there are certain symptomologies that could actually be helpful in the functioning society. So focus on a person's strength, not even necessarily their diagnosis, just at where their strength lies. Look to alternative ways to de-escalate a person. So if someone's having a really stressful day or a behavior challenge, look for alternative ways to de-escalate that moment that might not potentially re-traumatize the person. So sometimes we're looking to do like holds and crisis management and things like that. Or, you know, I love the, oh, just take a breath and calm down. Like, that's not going to de-escalate a person necessarily in the moment. If you tell me to calm down while I'm upset, that's not going to do it for me. So we have to look at alternative ways to do that. And then we have to look at our organizations and how our policies and procedures are focusing on trauma-informed approaches. So from an organizational level, so those of you who are administrators or advocates that are looking to change systems, let's look at our organizational policies on asking clients or our service recipients to become involved in the planning process. Let's do needs assessments. Let's train our clinical and our non-clinical staff. Let's create a safe, welcoming, calm environment. Let's prevent that secondary trauma in our staff by providing support to them, knowing that they're hearing about people's trauma. And let's increase our staff retention, right? To break that cycle that we talked about earlier. Let's hire or look to train that trauma-informed workforce. Let's screen for trauma. Let's engage some other folks that might be a resource for us. And again, let's turn our treatments to client empowerment, client choice, support networks of collaboration, increase trust and safety, and our own trustworthiness. And I can't say it anymore. Training, 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 training. As clinicians and organizations, we really need to start recognizing that this issue exists and just move forward with our training procedures. Oh my gosh, it's already 11:30. Okay, so this is the questionnaire, and I'm just going to go over this like really quickly, but this is a questionnaire that I found on Crisis Prevention Institute. It's fabulous. You could use this on an intake. You can use this in your admission packets, and it's something that you give the person and you say, what helps you? What helps you when you're in a really bad situation? What helps you calm down? What helps you feel better? What has worked for you? And this is, I'm going to send this to Diana and she'll include it with the slides for you. Who is a person that we can reach out to if you're upset? What are the triggers that you know make you upset? Being touched, being isolated, a door open, a door closed, people in uniform, any particular time of the day? Do you have a preference of staff? Is there anything that would assist you in feeling safe here? Think about that. Think about an organization handing this, or a clinician giving this to a person. Think about how empowering that is. So I'm just going to briefly tell this story, and then we'll go into some questions, and then we're going to have to move on. I didn't realize how much time already has gone. My goodness. So this is a story called The Unexplained Suicide. I worked with an adult who was 32 and had a history of increased physical aggression towards self and others. So there was a lot of self-injurious behavior that would happen, punching herself in the head, hitting herself on the floor, almost would look like what some would consider to be a tantrum behavior, as well as like flipping tables, throwing objects, and going after peers and staff. And it always seemed to be around the same time of the year. And when I said earlier about things falling off, I was reading some documents. This had gone on for a little while, and I was reading some documents, and I found something that said that when the person was 17, witnessed her mother's suicide. She had walked in to find her mom had committed suicide. And nobody on the team knew this, not even the person's guardian, because sometimes guardians through the state change, right? So information falls off. There's only so much information that we can keep. So we had a meeting. I called an IDT, and we had a meeting, and no one knew, and it was verified through the documents and through other people that had been involved in care. And it did turn out to be that time of the year where these very high increased behavior episodes would happen. I mean, we would have to remove the person and leave them in a room that was padded for their own safety, just because, with nothing in it, just because there was so much damage happening to other people and herself. So, and the person also had a history of untrue and accusatory statements to staff. So even if the person was saying it, no one was really believing them. So this is why it's really important to keep records together and to make sure we have good communication and have these things documented. All right, so is everybody okay? Only because I wanted to check to see where everybody was at. I'm going to go over ABA very quickly. We have a sanctuary weekly. Oh, very nice. Question 1, page again. Oh, Stephen, this is going to be distributed to everybody, so you're going to have access to this. Okay, hold on. Oh, thank you for this. I asked the question with sincerity and great respect. I'm a proud parent. Oh, wonderful. Yes. Okay, who said this? I don't know. Stephanie. Stephanie, this is one of the reasons why this this presentation was born. There is a new, better way of ABA coming, just so you know. So Stephanie said that they're a proud parent of a profoundly autistic child, also a trauma-informed public health professional, and many people that have had ABA itself considered to be traumatizing. In what ways in this field of ABA centering their voices and acknowledging this data as legitimate? That's part of the reason why I'm here, is to say that. So thank you for sharing that. Just trying to think. Oh, well, thank you, Stephen. I'm glad you're enjoying it. I hope everybody's enjoying it and you're not running away. Okay, so what is ABA? I'm going to just fly through this really quickly because you can read a lot of this on your slides. So ABA focuses on behavior, right? And what is behavior? The action of any living organism. And as we mentioned earlier, back to that learning history, behavior is learned. Our experiences shape our behavior, right? So if we look at one trial learning, as a way. So over time, our behavior is shaped up, but we also have that one trial learning. So if you think about it, I always say like riding a roller coaster. Some of you love riding a roller coaster. You went on it one time and you said, yes, this is it. I'm going to keep chasing this adrenaline. And other people said, oh, heck no, I am never going on that roller coaster again. Same thing with like a hot stove, right? People touch a hot stove and they know, oh, not touching it again. By the way, unless they like the feeling of being burned, but that's a whole nother presentation. So we have experiences over time that shape our behavior and one trial learning, one and done. If behavior can be learned, behavior can be changed. So we could decrease a maladaptive behavior, increase an adaptive behavior, or learn a new skill. Okay, so this is the formal definition. I'm not going to get into this formal definition. As I said, you guys can read this. You're all going to have access to the slides after. But generally, let's see, I'm frozen again. I don't know why it's not going forward. Whoop. Okay.
Excuse me, guys. So I do want to add that this is being recorded and it's going to be posted in our Families Together website.
Thank you, Priscilla. Okay, so in general terms, ABA is a science that assesses behavior and what environmental effects are reliably influencing socially significant behavior. Now, social significance is not for the society necessarily at large. It's for the person. It has to be socially significant for the person. ABA is an evidence-based applied science, so it focuses on systematic approaches, assessments, pairing, empirically based interventions, a technology of behavior change, aka the recipe, so we can all follow it. Data collection, we look for trends, we look for rates, we look for duration. Then we put it all in graphs and we can get a visual analysis if things are working, things are not working. And then we do our evaluation and our monitoring, which includes maintenance and generalization. So maintenance and generalization, again, is maintenance is maintaining over time without tech support. And generalization means it can happen across multiple different places, settings, without direct intervention. I bring up pairing here specifically. So we talked about assessments and how assessments can be more trauma-informed, but pairing is very important. Pairing is that developing trust and rapport with our folks, which means reinforcement, consistency, and respect. Respect of the person. So these are our 7 dimensions. Some people remember this as Batcave, but you can read this on your own. And then included in the slides is going to be this little YouTube video that you can click on and watch this really cute cartoon. Thank you, Dr. Amanda Kelly. So applied, it has to be important to the individual. It has to be behavioral, which means it has to be physical events that we can see that could be measured. It has to be conceptually systematic. All interventions back to behavior principles. It has to be effective, socially valid for the person. It has to be technological. Components described in details, AKA the recipe. It has to be analytic, showing that what we did demonstrated control over the behavior, meaning increased behavior or decreased behavior. And it has to have generality. It has to be seen over extended period of time without support. So we have to predict behavior, find the function of behavior in order to identify the skill that the person needs to build and teach and establish an alternative behavior. It's based on ABC, antecedent, what happens before the behavior, consequence, what happens after. It's not the bad thing that happens after. It's just the thing that happens after. Okay, so we do functional assessments. to identify what is happening in the person's life. Why is the person doing what they're doing? Developing that cause and effect relationship. Oh, let's move forward. These are the functions of behavior. So people, right? We all want things. We all do things to get things. Attention, escape or avoidance. I want a tangible. I want coffee. Or it could be automatic. Could be pain, sensory, or a private event. So I want attention. I want to escape something that's not great or avoid it. I always say, like, you know, when you call in sick to work, that's escape maintain behavior. If you hit snooze on the alarm because you don't want to go in and you're going to go in late, that's avoidance. I'll take coffee from someone, that's tangible, and automatic is just kind of everywhere. It could be pain, sensory, or a private event, like my friend Maddie.
Donna, we have a question by Stephanie.
Oh, sure.
She wrote, since stimming repetitive movements helps people regulate stress and trauma response, why does ABA train children to stop stimming when it is not physically harming self or others?
I don't know.
I just like to add that I am an RBT, and we don't really make a child stop this movement unless it is harmful.
Right. Thank you, Priscilla. So you answered that question all on your own.
Yeah.
Yeah, I don't know why some ABA practitioners do that. I can't speak for all of us. I stim all the time. I don't know if you guys are here, but like I'm flipping my ring around, right? Because I'm in a situation where I'm like a little nervous. I'm like talking into just my screen and presenting to, I don't know, 100 of you. So yeah, I mean, isn't that a form of stimming, right? I'm regulating my anxiety. Some people do this. Some people are at meetings and they're shaking their leg. Come on, you all know that you're doing this, or you have coworkers that do this all the time. So what does it matter that someone needs to bounce around if it's not an issue and it's not hurting themselves? Then I say go for it. Thank you, Priscilla. Okay, so when we design behavior support plans, we design them to break the if-then contingency. So I like roller coasters. If I go on a roller coaster, then I'm going to be happy, right? Like that's my if-then. We all know if we exercise, we're going to feel stronger. And our folks know that if I pull my own hair, my mom's going to come running, my dad's going to come running, my staff's going to come running. It's the same thing. So we're looking to break those if-then contingencies so we can intervene proactively. We're going to try to stay away from the reactive approaches. So we're going to look to teach new skills or come up with antecedent interventions, which is better than reactive treatment. We don't want those physiological crisis situations to occur. I don't ever want to put my hands on someone unless I absolutely have to maintain their safety. I'm trying to avoid potential re-traumatization. So we're going to just talk about reinforcement and punishment very quickly. And again, you could read this. There's a lot of technical terms here. Don't get caught up in the minutia of this if you're trying to follow along. It's literally what I'm saying. A reinforcer is anything that is introduced. So I give it to you or I take it away, which will increase the chances of the behavior occurring again in the future. Could be food, activities, money, socializing, praise. So how can negative reinforcement increase behavior? Well, if any of you have left this boring lecture, then you have been negatively reinforced because you have removed yourself from a very unpleasant event. So negative reinforcement removes an unpleasant event. It makes you go, ah. It's leaving the concert if the music is too loud. It's taking an aspirin if you have a headache. So those are the things that increase the future frequency of your behavior again in the future. So even though the word negative is in there, it doesn't mean it's a bad thing. It just is a minus. It's removing it. So positive and negative should always be looked at as a plus and a minus. I'm either adding something to you or I'm removing something from you, but that's going to make you feel so good. Hopefully that made sense to everybody. These are the formal definitions. We're not going to get stuck in that. I will talk about differential reinforcement because when problem behavior is happening, we could be reinforcing the problem behavior and not even realizing it. So what we look to do is we look to reinforce the skill building on one end and not reinforce the challenge that might be happening or the challenging behavior that might be happening. Again, you could read all about this and hopefully I'll be back at some point to give everybody another talk. All right, so these are the different differential reinforcement procedures. It's an alternative behavior, which is something that's an alternative to the challenge. Other behavior, which is any other behavior, or low rates of behavior, which is the declining rates of behavior. And you'll see a DRL a lot in the classrooms. Okay, I'm trying to go forward. It's not letting me. Hopefully everybody's still with me. Okay, so there are some risks of reinforcement, like you can get it too much, right? It's not worth working for anymore. You can get bored with it. You might be getting it at home and not at school and vice versa. Or we all know that child that we've seen screaming and crying in the supermarket because mom's not giving them that cookie. That's considered to be an extinction burst. I'm going to behave terribly until I get what I want. Or terribly to you. I'm going to try to like annoy you, basically. Some of these are really like my favorite procedures to use. An NCR is a non-contingent reinforcement procedure. It just basically means you don't need to do anything. You just need to be here. And if you're here, I'm going to give you something that you love, whether it be my attention, whether it be an activity, whether it be whatever you like. I'm just going to give it to you on a time basis just for being here. It's no different than when we are kind to each other just on a regular basis. It's just being kind. FCT is functional communication training, and I really feel that communication is a lot of the reasons why people engage in challenging behavior, because we're not understanding each other. Okay, I'm just going to go over punishment. So punishment is either added or removed to decrease behavior. Natural consequences are not punishment. So if someone destroys a room and has to restore the environment, that's not a punishment. That's just a natural consequence. The best way I always look at punishment is if it's something that you would expect yourself to do, then it's not punishment, right? So if I wet the bed in the middle of the night, I'll change my sheets. I won't necessarily wash them right away, but I'll definitely change my sheets and get myself washed up. But I wouldn't expect myself to wake everybody up in the middle of the night, change everybody's sheets, or do that for a week. Formal definitions, again, that'll be on your slides. Punishment is really not a good thing to engage in for so many reasons. People learn by modeling and imitation and imitating what people do. So you're modeling that. So if you're providing a punishment procedure to someone, other people are learning that. There's a lot of emotional responses. It could lead to aggressive behavior, escape behavior, of course, trauma, behavior contrast. The effects are very temporary. It damages relationships. And this could include even something like, you know, shaking your head, saying the word no, don't do that. Those are all reprimands. So those are all like positive punishers. So I always train my staff to use reinforcement rather than punishment. As a matter of fact, the last few slides have been from my staff training. So some punishment procedures are reprimands, response blocking, and that goes to that question, Priscilla, that person asked in regards to blocking responses from stimming. It's technically a punishment procedure. Response interruption, overcorrection, timeout, or response cost. Response cost is when you remove something from someone. Sorry, I just froze again. Just getting very concerned about the time because I want to leave some time for questions. I'm frozen. Uh-oh. Now I'm spinning. I'm so sorry. I told you I wasn't good at technology.
There it goes.
Oh, yay. Okay, thank you. So again, the difference between negative reinforcement and positive punishment is negative reinforcement is the unpleasant event is removed and the behavior is increased. So reinforcement always, the behavior goes up. Positive punishment is the unpleasant event is added and the behavior is decreased. Okay. So I'm not going to tell the story about my military family because we don't have time. But if we have time, I'll come back to it. I do want to go over this because, again, this leads to the ABA, some of the misconceptions about ABA. So all behavior change programs must be safe involved for all involved, right? So safety and doing no harm is our very first thing that we have to consider. Everyone has the right to safe and humane treatment and the right to the least restrictive alternative, right? I think we can all agree on that. Dr. Awada says, and he explains punishment procedures in the use of ABA as this. If all other less intrusive treatments with sufficient research base to provide a chance of success has failed, so you have exhausted every other positive intervention, that the use of punishment is the only ethical option. The reason why I bring that up here is I want you to think about the medical model, right? You go to the doctor or you have a cold, right? You have a cold and you're like, oh, let me take a Tylenol. Oh, let me take an Advil cold and sinus. Oh, let me, put a Vicks on my chest or put something on my head or take a nap. And none of that works, right? Then you go to the doctor and the doctor's like, oh, okay, you don't have a fever, so just go home. Call me if you need anything. And then you call the doctor the next day and then they give you an antibiotic, right? And then maybe that doesn't solve anything. And you go back to the doctor and then he goes, okay, let's do some blood work. And maybe then that doesn't do anything. And then they say, okay, well, you know what? Maybe you need an MRI or let's do a scan, right? So each thing is layering, right? We're doing the least restrictive first and then moving on. And then eventually you might need surgery, right? Most restrictive. So if you look at ABA treatment in the same way in that medical model, you'll understand that there is a hierarchy. We're not supposed to just jump to the surgery right away, right? If you went to a doctor that did that, that would be awful. Or our responsibility is to start with least restrictive and move all the way through. Punishment should be the last thing utilized unless it's the only option. And again, to maintain safety. So if someone was running in the middle of the street and they weren't stopping, I would do a hold. That would be the perfect example of when to do a hold. Okay, so again, I'm not going to tell the story of my military family. Now, this is going to answer the question earlier, and I'm sorry I forgot the person who mentioned it, about ABA and trauma-informed care and how it works together. All right, so this is on, if you look this up, actually, I can send the article along with the slide handouts. This is Rajamaran, Austin, Geaver, I can never say that last name, Donnelly and Hanley from 2002, where they looked at how trauma-informed care and ABA actually could work in conjunction, okay? So based on what I just told you about ABA. All right, so trauma-informed care acknowledges trauma and its potential impact, right, on the individual. ABA says we use less intrusive behavior support approaches, right? We just talked about that. If unknown, we assume all people have trauma and we pair ourselves with all the good things, right? That's what we need to do. We need to pair ourselves with people in order to have a really good therapeutic relationship. We pair ourselves with all the good things. Okay, next. Trauma-informed care ensures safety and trust. We have, and we can set up our environments and ourselves to be free from impending harm. Any environmental constructs, our body language, and we have the least restrictive procedures that we have to use first and foremost. And we're going to restrict restraint use wherever possible. If we just follow our ethical guidelines as ABA practitioners, we are ensuring safety and trust. Promote choice and a shared governance. So shared governance, for those of you who do not know, is enabling somebody to have a choice in their care, right? We're all going to come up with this together. It's the person's care plan. They should be involved. So ABA supports client control, choice, and autonomy. Goal selection, monitoring, our collaboration throughout, and people's preferences. We do something called preference assessments very early on in the assessment process, which looks at what people like to engage in. What are my preferences in life? Because I'll tell you, if I needed a drink and I just went like this and signed drink for someone, and they constantly brought me water, but I wanted coffee, oh, there'd be a problem. So hopefully everybody's giggling at that right now. Okay. Trauma-informed care emphasizes skill building. And ABA also emphasizes skill building. We teach skills. We teach new skills. We teach functionally equivalent alternatives. We teach pivotal skills, things that lead people to the next cusp of the latest and the greatest thing for their lives. So ABA and trauma-informed care can work together. And for the person who did bring that up, I have to say that Dr. Hanley, if you go on his website, which is later on in the resources, you'll see that he apologizes for other ABA practitioners who did not look at things in this way. So we're going to limit level 3 treatment plans, which are the most restrictive. We're going to look at consent, which is the legal form, but also assent. If someone's walking away from a treatment, I'm not going to force them back in. We're going to try to limit timeout procedures, any restraints, or even physical prompting, because even just something like this could potentially re-traumatize a person. We're going to monitor a person's emotional responses, and we're going to take more of a proactive approach in ABA, which is possible. I'll tell the story if we have time later. Non-compliance in the supervisee. This is a good one. The ethics code for behavior analysts says a few things, and all the codes will be listed. And as I said, they'll be here for your review, and they're also in the reference page. I'm not going to read these all. But the overall foundational principles is we have to engage in treatment that's going to be in benefit for others. We have to treat others with compassion, dignity, and respect. We have to behave with integrity. And we have to ensure our own competence. If this isn't speaking directly to trauma-informed care, I don't know what is. So the codes are going to be highlighted, highlighted, highlighted. They're all here for your review. You can always take a look at them on the board website. They're here. This is a code that all behavior analysts have to subscribe to. But I am going to leave it on the last slide and just give you a summary. of this. There are over 11 codes. Hold on, sorry. My note page didn't come up on my slide presentation. There are 11 codes that protect our clients that ask us to do no harm, to put the clients first, to provide choice, to provide collaboration, to provide resources and referrals, to minimize risk, and to treat through positive reinforcement. 11 codes for ABA. So looking at that as an ABA and a BCBA, and I'm proud to be a BCBA, but looking at it through that lens, it speaks to the necessity for trauma-informed care in our practice. And just as a little side note, Skinner, one of my very favorite quotes of Skinner, which is loosely quoted from Eden too, is what is love other than the use of positive reinforcement and vice versa. Collaboration is really important. So all of you advocates, all of you, your families, you have a right to discuss things with your team. And again, thank you, Merriam-Webster, on what collaboration is. The skills needed to be a good collaborator is build and maintain relationships, avoid negative talk about other professionals, speak in clear language or layman's terms, foster good communication, educate, explain, ask questions. Parents, please ask questions. If you're unsure about a field or a perspective, just ask. Ask your clinicians. We all have a different perspective coming into this. So just make sure it's a good fit. Make sure the person is speaking your language and is explaining things to you. Reflect back. If you don't understand what the person is saying, reframe it to them. Say, I heard you say this. And they'll chime in if they didn't, if that was misunderstood. And share information. Share this information. Share everything that I share with you. There's resources, there's going to be slides, there's going to be handouts. I teach, because collaboration is not taught in school. I teach my incoming students these key clinical competencies: communication, understanding your role, knowledge of the role of others, ability to function as a team, leadership. Look at the goal. Look at what the goal is for the person and what that means to the person. How is the treatment implemented? Is it trauma-informed? These are some questions that you can ask or share with your clinicians. And again, this will be part of the slides. And then that's it. I know I just ran through that, but I definitely wanted to go through that. And I'll share some of my final thoughts as I add the poll back in here. I'm going to ask the same poll question again. I have been exposed to trauma. Now having a different framework of what trauma is. How many of you think that you've been exposed to trauma? Before it was like 84%. And while you're all answering that, I'll just let you know, like, my whole entire career has been built on how to get a collaborative understanding of someone's point of view. We all have individual experiences, and it's really so important for us to remain focused on the person's perspective, because that is so important. So our future direction should be in the areas of defining trauma, defining observable symptoms, researching and publishing treatment effects, developing advanced trainings for clinicians and ABA clinicians. Again, why I'm in the field, why I'm teaching supervision, advancing ABA practice, and collaborating. Wow, we're up to 97% right now. 97% now. That says an awful lot. Thank you all for spending the day with me today. I hope I didn't go too fast. I tried not to. We will have some time for some questions. I just want to say that our work involves increasing quality of life for our folks, providing choices, being observant, being respectful, being patient, being kind, and having empathy, being accurate, having good, positive communication with ourselves, with our team, with each other as a field. And lastly, just do good. Do good for yourself, do good for our folks. Thank you so much all for your time and your attention and for always working on doing good. I truly appreciate all the work and all your attention today. And I guess we will have time for questions, and all my resources are here. I didn't just make this stuff up. It's all out there, I promise.
Donna, before Priscilla closes out, we have amazing, information in the chat, and I want to really thank individuals. We have someone, a family peer advocate, Rebecca Sellers, that says, "I just want to say my son has autism and sat here and listened to your presentation. Due to a bad experience, he has balked about going back to therapy, and now said that he will give it another chance." And thank you. And that's awesome, right? You got to look at this chat. Oh my God, great question. So go ahead, guys.
Okay, I don't want to cry. Oh my gosh, I'm so grateful to hear that. Thank you so much for your courage and in sharing that. Thank you for trusting all of us and me to share that information. It's amazing.
Guys, we got 7 minutes. Go ahead, ask your questions. I know your questions are in the chat.
If not, I'm going to go back to those stories. And I'm getting a little, whew, I need my coffee. Oh, and by the way, don't forget to be awesome. That's what my mug says. So that's for all of you. Don't forget to be awesome every day.
Let me see.
I have a question and I'm probably going to find it. So let me introduce myself. My name is Jennifer and I'm a psychiatric social worker with the Bronx Children Mobile Crisis Team.
Hi, Jennifer.
And hi. So you probably did answer this question already. So we usually get all our clientele from New York City's hotline when people call in if they're having any mental health crises. And we usually do get a lot of cases where we do get children that have the autism diagnosis, and they will be very severe physical aggression in the home where there's a safety concern. But I think I can speak not only for myself, but for my colleagues as well. We usually never know how to properly refer the family in regards to that situation. So we usually try to encourage them to do the OPWDD process, which is going to be a long process, but we never really feel like we're actually really helping the family. And just watching and seeing your presentation, I was able to understand a little more in depth that there may be other underlying issues going on aside from looking at the diagnosis. So just any information, and even anyone that's actually participating in this training may have in regards to like maybe a program that they may be aware of that may be in New York City, that we will be able to provide like maybe proper referrals in regards to like any concerns of like physical aggression or behaviors in the home would be helpful.
Well, Jennifer, thank you so much for sharing that. It's so what I have found in doing all this with Diana and Priscilla is that New Jersey and New York, wow, we have such different modes of doing things. We really do, right, Diana? I mean, I'm not sure if there's any specific place that people can go in New Jersey, and maybe this is why I'm connected with the advocate's office. In New Jersey, families can call one number and they can get a plethora of people coming through Trinitas or through the psychiatric helpline. And we come out, and there's a BCBA, there's a social worker, there's a psychiatrist. People don't necessarily have to go to a place or go to a hospital. They could be stabilized in their own home.
Donna, excuse me,
Yes.
I'm sorry to interrupt, but
No, absolutely.
Jennifer, someone just responded that New York START is a crisis services. for people with IDD. So it says it's across all New York State. So I apologize, Donna, but I wanted to put that out there. New York Start. Okay, Jennifer? Go ahead, Donna.
Oh,
Thank
this is
you.
awesome. See, this is why I love this, because we can all help each other. What is it called? New York Start?
New York Start, right? It's a crisis service. It's a crisis service program.
Okay, but is it DD informed though? Is it informed with our different abilities? I think that's part of the.
I think in this case, as she put, for intellectual developmental disabilities, so it's probably geared for people
Okay.
with autism, because that was her concern. Was
Okay.
that the families, the kids that were coming in, the calls were from individuals that had autism and these challenges.
Oh, awesome. Oh, Debbie, yes. I just got into the chat, by the way. Thank you, Jennifer. Debbie used to work there. So if you want to unmute Debbie, feel free. Let's have at it.
Hi, everyone. I'm
Oh, I love
Debbie.
your mountains.
Oh, thank you. I used to work for New York Start in the Western New York region. And they do systemic and individual crisis intervention for anyone over age 6 who is diagnosed with an intellectual or developmental disability with co-occurring behavioral health or mental health challenges. I did put the website for the in the chat, and they do have a 24-hour crisis hotline number also. Interestingly enough, I actually used to work for our local crisis center in Western New York also. And that's what attracted me to start, is because there wasn't any service for those individuals on the autism spectrum or other IDD type disabilities. So I'm trying to find the phone number for, okay, Bronx, Manhattan, and Queens. Yeah, honestly, I'll just cut and paste all of this.
Thank you so much.
There's 5 different regions of services across the state, which are, if you go to the link that I shared, it breaks down the districts, the different websites, and the different phone numbers to access those services.
Thank you so much.
You're
See,
very
we all have to
welcome.
come together. It takes a community. It really does.
For those that are looking for the link, when you sign off, you'll be able, the survey will come on.
Okay, I also wanted to go back to Stephanie, who said, in what ways are you incorporating feedback from autistic adults who have experienced ABA in as many ways as possible, if that is an answer? Stephanie, I always take feedback. So even in just anything, our whole job is about feedback. What's working, what's not working. I like to check in with whoever I'm working with on a regular basis. I tend to be there multiple times a week, particularly in the beginning, just listening, what works, what doesn't work. I am that way in both my social work practice, because I do psychotherapy, as well as an ABA, as a Bcba. I always look for feedback, because if people don't tell me what they need, then I can't be effective at my job. So I seek that out on a regular basis and look to build that. And if it's becoming effective in my practice based on data, right, then we could research it and we can kind of put it out there for all the clinicians. It's just that, unfortunately, that does take some time. So we all do it one step at a time, right? Anything's possible.
That's your motto.
Which is true. Right? Stephanie, I hope that answered your question.
Yeah, there were great questions in the chat.
I mean, adults who experienced ABA as children. Oh, it's the same answer. Even if people aren't, I put up all my information. So if anybody that's here has had something happen in ABA, like, feel free, reach out to me, let me know about it. Yeah, I want to hear about everybody's experiences, because sometimes we even we see it, right? We see it happening to someone else. And it could have been or may have been a traumatizing experience. I can't, it's hard because I feel like I have to apologize for my peers before me, but you know, every science when it's new, how we start off, right? And we just know better and do better. So I think that ABA is also coming around to the know better and do better. And I have seen some training change over the years. So hopefully that answered your question. Oh, is FCT training like pragmatic speech? Yes. So functional communication training is just that. It's teaching communication and verbal behavior protocols. Modeling brain development by putting, I haven't. So thank you so much for sharing that, Maria. I appreciate that. Is it common for those with trauma to understand the actions are having based on past or present trauma? I don't understand that question, Maria. If you're still here, if you wouldn't mind unmuting.
Is it common basically for those that are having like behavioral challenges, or even the person to even have an understanding that it stems from that trauma, I guess is what I'm asking.
Yeah.
It's pretty uncommon across the board that you almost have to recognize it as the therapist and kind of help them understand it and psychoeducationally kind of do that piece with them.
That's a great question. And you know what? I wish I had a specific answer for you. It really does depend upon the person. As I mentioned earlier, like there are certain people that it's just coming out. And there are certain times even in our own trauma, right? We don't know it until it's like there, right? Suddenly like something might happen and like, boom, there it is right in front of us. But what we can do is start to be more sensitive. And if we just, again, presume that everybody has that trauma, particularly in ABA, we're not going to be doing things like, you know, pulling people's arms so they can pick up a pen, right? Or even prompting them in that way. Or, you know, doing things like compliance. That was the compliance story I was going to tell. Some of my supervisees or my students will even write a plan that's like, oh, I'm writing this plan for non-compliance. And my question to them is always, do you guys think that you want to teach somebody a skill where they're going to be like compliant all the time? Are you compliant all the time? Like, what is that? We can't train somebody or teach somebody to just be compliant like a good little boy or girl. Like, that's not what our job is. Our job is to teach a skill. And being compliant isn't a skill, right? Sitting in a chair, listening to your teacher, doing your work, right? Those are skills. Using the bathroom, asking a question, labeling an emotion, those are skills. Being compliant is not a skill, if that makes sense.
You would definitely like the RCD model and should definitely check it out because it basically puts the teachers kind of build on their strengths in the classroom before they're even sent out of the classroom. And then when they're sent out of the classroom, they actually have to create their own plan themselves, even if it takes all day of them sitting there. They have to create the plan of what are you going to do the next time this happens? Who did you offend? All those different pieces are put into place so that they have an awareness. So it's a pretty powerful program, and I wish more schools did it for sure.
Oh, that sounds great. Oh, well, maybe I can see if if I can pull that in somehow, right? That's all I've been doing is like a piece of this and a piece of that and a piece of this and a piece of that. The ACT model is really a great model because it does teach people to work towards what they want.
Right. And
so it's a really nice behavioral model. So if you want to take a look at that as well, it's a great intervention with kids even. So
I will. Thank you.
Of course. Thank you so much. Whew.
It is 12:03.
Oh my gosh.
Yes, Priscilla will have her closing remarks. I want to thank everyone for being here and staying on as long as you have. And I really appreciate it. Priscilla and I and Donna, we all appreciate your feedback. Priscilla, if you want to just take it over and just do your closing remarks. It is 12:04.
All righty. Second.
gonna get my screen off here.
Huh?
I'm gonna shut my screen off because I want to see everybody now. Oh, look how many people are here. Hi, everybody.
We had 103. Some of them had to come off, but you had a nice amount of individuals.
Okay, so
Congratulations.
can you guys hear me?
Yes.
All right, so I want to take a moment to thank you all for being here today. Thank you for taking the time to participate and share. We hope you enjoy and learn from this training as much as we enjoy delivering it. As a reminder, please know that the survey will pop up on your screen once this meeting has ended. Please complete the survey and the survey will count as proof of attendance. Those who do not complete the survey will not receive a certificate of participation, which is equivalent to 2 hours of continuing education credits for your FPA credentialing. Note that no CEU credits will be offered with this training. You will receive copies of the slides and other information that was shared. If you would like to revisit the webinar, please visit our website at ftnys.org. Have a wonderful day and a better weekend. Sending love your way. Sincerely, the New York Regional Parent Advisors and Donna.
Thank you so much.
Bye, everyone. Thank you so much. Happy Friday.
Yes. Oh, like Priscilla says, happy Friday.
Oh,
I love it.
I like it.
I love it.
Hello. Hello, I have a question. How do you fill this out at the end of the thing? Because I don't know much about electronics.
So once you leave the meeting, it's a survey is gonna pop up, and it's a short question. It's you just pick your answers. It's pretty simple. You don't have to write anything. You just read your questions and pick your answers. It's question choice.
Yeah. Anyone else has a question before we actually save our recording, our chat? Anyone else has anything else?
I have a question, Diana. This is Jacqueline Pittman. So I never received the registration to sign on, but Carmen Cruz for Families on the Move has sent it to me. It had came up under her name. I changed my name to Jacqueline Pittman, so hopefully this won't be a discrepancy for me to get the 2 hours in the certificate.
Okay. Okay, I will look into that. Priscilla and I will look into that. Okay.
But I'm going to do the survey though, either way.
Okay, what was her name that you used?
It was Carmen Cruz for Families on the Move. She forwarded me the login because I never received it.
Okay. Sounds good. I'll look out for that. Okay.
I'm sorry, they had a sign-in sheet at the beginning because I didn't see it.
Nope, you're in, so we have your name. Once you
Myra
log out right
Solomon.
now, there's gonna be a survey and that's your sign-in sheet.
Okay, thank you.
Okay.
Mhm.
Priscilla, if you want, save the recording because I have to leave. I have to hop onto another. But
yes, not to worry. I'll take care of it.
Alrighty, and the chat and everything.
I'll take care of it.
Thank you. Okay. Have a good one, guys.
Bye, Diana. Thank you.
Everybody. Thank
You're
you,
welcome.
Donna.
Thank you.
Thank you. Priscilla, I'll hang out with you.
All right.
I'm gonna mute.
I'm not gonna hit end then, because I don't want to do anything.
No, you can't. No. Let me do it.
No.
I'll
Yeah,
do it.
exactly. I'm just gonna shrink and do what I gotta do. Okay.
Don't shrink. Don't you ever shrink. You keep being you.
Okay. Thank you.
Hello? Hello?
Yes.
I don't see any survey.
Okay, so you can leave the meeting and it'll pop up.
Oh, I have to leave.
Yes.
Oh, okay, sorry. Thank you.
All right, thank you.
Hi, Priscilla. I just left the meeting and nothing came up. So I don't know if that's a glitch or something that's going on, but I just left and I just returned. I was like, oh my God, I hope they're still there because that is not coming up.
Try again.
Okay.
That's strange.
Yeah, that's what I thought. I was like, let me get back there. Make sure that they know that this is not popping up. Okay.
Priscilla, I think I have to leave the meeting.
No. If
Yeah,
you
but
leave, I won't be able to save anything.
even though if I make you co-host or host? Can I make you the host?
Okay, make me host.
Okay. Okay, I'm making you a host, okay? Because it's not letting me go on to the other meeting for whatever reason, okay?
Yeah, okay.
Thank you again for holding it down. Donna, congratulations and thank you to everyone.
Thank you.
Thank you.
Thank you so much. Have a good weekend.
You